Hi, everyone. My name is Craig Cole, and I'm a myeloma researcher at Michigan State University, Karmanos Cancer Institute at McLaren Greater Lansing. I'd like to thank the MMRF for inviting me to talk to you today about the diagnosis and initial treatment of multiple myeloma. And so multiple myeloma is a cancer of the plasma cells. The plasma cells are immune cells that live inside the bone marrow of the body. And just like any other cell in the body, those plasma cells can become cancerous. And when plasma cells become cancerous, we call that multiple myeloma. Myeloma cells will produce in excess amounts of protein. On the right side of the screen, there's a picture of an antibody that looks like a Y. And antibodies have the heavy chains that we'll talk about in a bit, as well as light chains that fall off the side. And those plasma cells can produce excessive amounts of that protein, which are the telltale laboratory sign of myeloma. Also, because plasma cells live in the bone marrow, they can crowd out the normal cells that are being produced by the marrow, causing people to have anemia or low red blood counts. Those plasma cells can migrate from the bone marrow compartment to the long bones of the body, causing weakening of the bones and what we call lytic lesions and possibly bone fractures. It can also release calcium by causing weakening of the bones, which can cause patients to have fatigue. And that protein being produced by the myeloma cells, those antibodies, can actually get stuck in the filter of the kidney, causing patients' kidney function to deteriorate. So those are some of the signs and symptoms of myeloma. We'll talk about that also in a little bit. And one feature about myeloma is that all myeloma begins with the precursor disease, the monoclonal gammopathy of uncertain significance, or MGUS, that's on the left side of your screen. The risk of having MGUS turning into myeloma is actually low, about 1% per year. If the number of plasma cells is greater inside the bone marrow, greater than 10%, and the protein level is higher, we call that smoldering myeloma, with a higher risk of becoming multiple myeloma, about 10% per year. And if there's more than 20% plasma cells in the marrow, as well as having a M protein greater than 2 grams and having a free light chain greater than 20, then we call that high-risk smoldering myeloma, with a higher risk of turning into true multiple myeloma at 50%. And then, of course, there's multiple myeloma that we'll discuss throughout our talk today. Multiple myeloma is the second most common blood cancer, behind lymphoma, the most common blood cancer. Approximately 32,000 people were diagnosed with myeloma in 2020. And incredible enough that 131,000 people are living in a remission or living with myeloma at this time. And that number was just half that in 2014. So we've made remarkable strides in keeping patients alive with myeloma. It represents about 2% of all cancer cases, and it's a disease of adults, with the median age being 69 years of age. Some other statistics about myeloma is that it is more common in men than in women, as seen by the new cases on the left side of your screen. It is also much more common in Blacks and people of African descent than in Caucasians and all other races. And actually, that is not only true for African Americans, but people of African descent around the world. Because the incidence is higher, the death rate is actually higher for myeloma for people for African Americans and people of African descent, and again for men greater than women. And so again, some of the risk factors for myeloma is older age. It's very rare in younger people, male gender, and again race. That's more common in Blacks and in whites. Ashkenazi Jews have a higher risk of myeloma, and people of Irish descent have a higher incidence of myeloma. It's actually the incidence is lower in people of Asian descent and Native Americans. One important feature to know is that the first-degree relatives with myeloma have an increased risk of myeloma, and that's particularly true of people of African descent. Relatives of myeloma have more common or a higher risk of the monoclonal gammopathy of uncertain significance, that precursor disease of myeloma that we just talked about. So what are the symptoms of myeloma? Well, because myeloma causes low blood counts, we talked about how it's inside the bone marrow and can crowd out some of the normal cells, that patients become anemic. And anemia can cause weakness, fatigue. Also, because it crowds out the normal immune system, the patients have a higher risk of infection. So they can have recurrent infections as a presenting sign of myeloma. Because that protein can get stuck in the kidneys, like we talked about, it can cause low kidney function, which can cause weakness, fatigue, and confusion at times. And because it can cause bone damage, that those plasma cells will leave the bone marrow compartment and cause lytic lesions in the bone, patients can have bone pain. And also they can have high levels of calcium in the blood, which can cause increased thirst and confusion. About 20% of patients won't have any symptoms at all, which is an important feature to remember. One thing that we do know is that Black patients are more likely to have the hypercalcemia, the high calcium levels that we talked about, the renal dysfunction and anemia. And actually, people of African descent have lower chances of having the bone fractures, more common in Caucasians in the United States. Again, because myeloma is a cancer of the immune system, that patients with myeloma have a higher risk of infection, particularly urinary tract infections, pneumonias due to pneumococcus. And when infections are bad enough, patients can have sepsis, when they can have blood infections because of the lower immune system. Also, fungal infections and viral infections, particularly shingles and zoster, are more common in patients with myeloma. There are preventative strategies to IVIG or intravenous immunoglobulins, or donor antibodies, which can help protect patients against infection. Of course, the use of antibiotics, and not infrequently when patients are newly diagnosed with myeloma, that they'll require antibiotics. And of course, vaccines to help protect us from viruses and bacterial infections, but also, good hygiene, so good hand washing, avoiding close contacts, and make sure our dental health is up to date. Also, COVID-19, which is the pandemic that we've been living with more recently, it's really important to know your vulnerability of the area that you're in and what has happened with the pandemic at any particular time, because patients with myeloma have more susceptibility and more severe cases of COVID than other groups of patients. When patients are diagnosed with myeloma, it's important to set a path, to have a plan. And the best way to have a plan is to have the right team surrounding you, having the right tests performed, and to know what those tests mean, and the right treatment, to be empowered. And all these are points of empowerment that help patients cope better with the disease and fight the disease much better. So the right team. Connecting with a myeloma specialist, a doctor who diagnoses and treats high numbers of myeloma patients, that also will have access to clinical trials. To seek a second opinion. I do lots of second opinions for myeloma. I send my patients with myeloma for second opinions because it's good. It empowers patients. It gives them more knowledge from different people. And because myeloma therapies change so rapidly, it's important for you to know and for your providers to know all the new things are happening in myeloma. So a myeloma specialist and getting a second opinion are important parts of your treatment team. Also, the MMRF's online myeloma treatment locator can help locate where second opinions are and myeloma providers are. And I can't underemphasize how excellent the MMRF Patient Navigation Center is for my patients and for everyone that help build that team. They can help you do that. So what about those tests we talked about? Well, they're kind of broken into 4 categories for myeloma. The blood tests that are used to diagnose, follow, and risk stratify patients with myeloma. The urine tests that we've been using since 1844 to diagnose myeloma and follow the disease. Bone marrow biopsy at the time of diagnosis, and which is critical not only for diagnosis, but also risk stratification of the disease. And then imaging tests. We talked about how myeloma cells can go to the bone, and X-rays, MRIs, and PET scans have really become the absolute standard in assessing where the disease is at any particular times. So knowing your labs is definitely a point of empowerment. Understanding those labs and what they're for is critical. The CBC will tell you what the red blood cells, we talked about how myeloma can involve anemia and crowding out the normal immune system. So the CBC helps tell you the health of your immune system. The complete metabolic panel, a CMP, will measure the albumin, the calcium, the kidney function that we had talked about, the liver function. The beta-2 microglobulin, the B2M, is a little protein that is on plasma cells that are shed from the plasma cells and excreted in the urine. So that can help tell, especially at the time of diagnosis and during staging, about how much myeloma cells there are and if they're causing kidney damage. And then the main test, the SPEP, which helps detect how much M protein there is at the time of diagnosis, and it's in going down can tell you if the treatment is working. The immunofixation, or the IFIX, can tell you the type of antibody. We'll talk about that in a bit. And it's always important because 17% of patients will only produce those light chains, those little fragments of antibody that fall off the side. The free light chain assay can help tell, along with the urine test, to how much monoclonal protein there is. So the different types of protein, again, produced by those malignant plasma cells. There's the intact immunoglobulin, or that Y-shaped protein that we talked about at the very beginning. There are different types, IgG kappa, IgG lambda, IgA kappa, and IgA lambda. Those are intact antibodies that are produced by the myeloma cells about 80% of the time. About 17 to 20% of myeloma patients won't produce that intact immunoglobulin, but only produce light chains. We call that light chain myeloma. Those will either be kappa or lambda light chain, and those are that the myeloma cells are mutated enough where they're only producing the light chains. That is the protein that can get stuck in the kidney, causing kidney problems. And we also call that protein the Binch-Jones protein. And then a minority of myeloma patients the plasma cells will be so mutated that they won't produce any protein at all. And those are the asecretory and non-secretory myeloma patients, about 3% of myeloma cases. The urine tests, again, we've been using since 1844, discovered by Dr. Henry Binch-Jones. We've named the protein after him. The urine protein electrophoresis can detect that, especially on a 24-hour urine, to tell you how much monoclonal protein there is. And the imaging tests. We've been doing X-rays for myeloma since 1900, and it will show punched out lesions and areas of fracture related to the disease. But the newer imaging tests, the MRIs, CT scans, and the positron emission testing scans, the PET scans, are 85% more sensitive in picking up lytic lesions and really become, in the United States, one of the mainstays of assessment of bone disease and myeloma. To make the diagnosis, we do the bone marrow biopsy. And the bone marrow biopsy, of course, we go to the home of myeloma, of where those plasma cells are. And we count the plasma cells at the time of diagnosis, but also we look to see what were the mutations that caused the disease in the first place. One way is by counting the chromosomes, known as karyotyping, but really the FISH test, the FISH in situ hybridization test, definitely a term to know when you have myeloma, because it's really important in risk stratification for the disease and staging. We'll talk about that in a little bit. More recent studies that have been done is it not only to look at the chromosomes, but look at the individual genes that were involved in being mutated in multiple myeloma. So again, we look at the chromosomes. We can look at the closer at the chromosomes with the FISH testing. The newer tests looking at the DNA for mutations, gene expression profiling, next generation sequencing, which is rapidly becoming more and more involved in diagnosing myeloma, risk stratification, and at the time of diagnosis and at relapse. So we pull all those together. We pull the imaging studies, the x-rays and the PET scans, the urine protein tests and the blood protein tests on the SPEP and immunofixation. We pull genomic testing, chromosome testing, that FISH testing, which is really important, and the bone marrow analysis. And that gives us staging, prognosis, and risk assessment. Again, important tools in decision-making for the treatment of myeloma. Our staging system, the Revised International Staging System for Myeloma, or the RISS, there's only 3 stages in myeloma, 1, 2, and 3. And it's based on that beta-2 microglobulin, or the beta-2M that we had talked about. Low amounts of beta-2M are associated with stage 1. Higher amounts are stage 3, and in between is stage 2. Also looking at the cytogenetics, looking at that FISH testing. And so on the right side are the INSMART consensus guidelines of what's considered high-risk abnormalities. Translocation of the where the 4 and 14th chromosome are stuck together, where the 14th and 16th chromosome are stuck together, or 14-20. Missing chromosomes can also be associated with higher risk of myeloma, such as deletion of the 17th chromosome, or finding that there's a p53 mutation, which makes the cells mutate more when that particular gene is mutated. And also gain where there's one extra copy of chromosome 1p, or amplification where there's more than 3 copies of chromosome 1 are associated with higher risk disease. And we call double hit and triple hit when there are combinations of those abnormalities present. Most patients will be standard risk. They'll have other abnormalities, including triple chromosomes, excluding chromosome 1, or the 11-14 or 6-14 translocations are standard risk. And those are incorporated in the staging system, that high-risk patients are stage 3 when their beta-2 is high, or the absence of those would be stage 1 if their beta-2 is low. So it's important to know, again, surround yourself by the right treatment team, to know what treatment options are available based on your stage and risk profile that we had just mentioned. Be aware of the pros and cons of each treatment option, because I'll show you how there are multiple treatment options available. And clearly communicate your treatment goals and concerns, any side effects that you have, any social concerns that you have. Make sure that your team, your family are involved with your care to, again, surround yourself with the right team with the right treatment. And again, there have been so many breakthroughs in clinical trials. There's so many clinical trials available to find a clinical trial that's right for you at any point during your disease journey. There are lots of different therapies, again, that are available for myeloma. It's exciting. When I first started doing this, there were only 3 columns, and now there are multiple columns evolved in the therapeutic landscape of myeloma, including the immunomodulatory drugs, the IMiDs, with Thalamid, Revlimid, and Pomalyst, the proteasome inhibitors, including Velcade and Kyprolis and Laro. We still use chemotherapy to treat myeloma at times, including Cytoxan and Melphalan as the alkylators, and Melphalan we use during stem cell transplant. For the past almost 100 years, we've been using steroids to treat myeloma. We're still very dependent on the use of steroids, particularly dexamethasone and prednisone in some cases, to help those other drugs work better in fighting myeloma. And then when patients are at the time of relapse or involved in clinical trials, they're the novel mechanisms of action, the Feradac, selinexor, and venetoclax. We'll talk about those drugs a bit later. And the monoclonal antibodies, where these are drugs that help your body find the myeloma cells and get your immune system targeted precisely on the myeloma cells. One of the most precision therapies that there are to treat myeloma. The monoclonal antibodies, including Implicity, Darzalex, Sarlissa, and Blenrep. And the new cellular therapies, the CAR T therapies, which again are used in more relapsed refractory setting of the disease. Because of all those new therapies, there have been remarkable improvements in survival with myeloma. If you look at the black line back in the 60s, we're treating myeloma. You look at 5 years, that only 10%, 15% of patients were alive at 5 years back in the 60s with this disease. If you look as recent as 2010, that only at 5 years, there were only 60% of patients alive. You look at the blue line, that's where we are today. That's where we're even better than that today. You look at 5 years, 80 to 90% of patients are alive. And that line just keeps going out. And so there've been the implementation of science and those new drugs have improved survival, which is why there's so many patients with myeloma alive at this time. So what's the treatment paradigm for myeloma in 2022 and moving forward? Well, if a patient is a transplant candidate, if they can receive high-dose chemotherapy, then, or if they are unable to undergo high-dose chemotherapy with a transplant, that we start with an induction therapy. So the starting out therapy for multiple myeloma using those drugs that I had mentioned. If you're a transplant candidate, then we initiate transplant and go to consolidation therapy, followed by maintenance therapy. And if patients elect or are unable to receive a stem cell transplant, then they go from induction therapy directly into maintenance therapy. But the important point is that you see that these arrows move forward, that after we push the disease down, that we want to keep it down with some type of maintenance therapy. So the guiding principles for myeloma therapy is at the time of induction, there were multiple trials showing that 3 is better than 2, to use at least three drugs for induction therapy, aiming for the deepest response possible. Push the disease down as far as you can, because it will take only that much longer for the disease to try and come back up. And one way to push the disease even deeper, to push it down even further, is to consider stem cell transplant, either at the after induction therapy or later, because that will help get better, more long-term control over the disease. And of course, we have to always tailor this to individual patients to know best how to treat it, and especially what are the goals of a particular patient and their family in the treatment of myeloma. But those guiding principles can take you a long way. Again, measuring response to therapy, that it's important to know where your M protein is and how many plasma cells they find in your bone marrow, because that's where you're starting out with at the time, right where that stable disease is the how high the disease burden is at the time of diagnosis. And as you begin treatment, then you begin to reduce the amount of disease and the disease begins to shrink down. That M protein begins to go down. If it's gone down by 30%, that's a minor response. If it goes down by 50% from the start, that's a partial response. 90%, a very good partial response. And if the protein level disappears or if the light chains in bone marrow are negative, then we call that complete response, a stringent complete response. There are new techniques that can find disease at even lower amounts, either with next generation sequencing or flow cytometry, that can detect minimal residual disease inside the bone marrow below the level what our laboratory tests and standard bone marrow tests can do. And again, the idea is to try and drive the disease as low as possible. It's important to know your M protein so you know when to celebrate when you're in a complete response, and a very good partial response or a stringent response. So again, knowing those labs empowers you to know what's happening with your disease. So again, when we see new patients with myeloma, the first question we ask is, what are the goals of therapy? And is a particular patient a candidate for one dose of high-dose chemotherapy or an autologous stem cell transplant? Age is not a discriminator for autologous stem cell transplant, but comorbidities and other diseases might be. So it's important to talk to your doctor and get a second opinion. Am I a stem cell transplant? If you are or not, again, we start with an induction therapy. If you're not a transplant candidate, that induction therapy continues on through maintenance. And if you are a transplant candidate, you get 3 to 4, sometimes 5 cycles of an induction 3-drug or sometimes 4-drug regimen or clinical trial, followed by stem cell collection and 1 high dose of melphalan, followed by a stem cell rescue. So you're giving the stem cells back, which makes giving that high dose of chemotherapy that much safer. And after you recover from that transplant, patients either go to a consolidation or directly to maintenance therapy, depending on the regimen that's being used. It's important that the whole time that you're going through the active therapy for myeloma, and after transplant and during maintenance, to have supportive care, to make sure that your nutrition is good, that your teeth and dental care is good, and using those bone strengtheners to heal back the bones, and take the appropriate vitamins such as calcium and vitamin D to help strengthen the bones during the treatment of multiple myeloma. The preferred treatments are in the red. Recommended and other possible treatments are in blue in the middle, and green are induction therapies in certain circumstances. I think you'd see that most of them include 3-drug regimens and sometimes 4-drug regimens, but there's so many potential options. Again, that's why it's important to get a second opinion and talk to your doctor about your goals of care to find the right induction therapy for you. But again, our Revlimid, Velcade, and dexamethasone, or RVD, is kind of the standard induction therapy for both transplant eligible and ineligible patients. Sometimes we engage those antibodies earlier for transplant ineligible patients using daratumumab or Darzalex, Revlimid, and dexamethasone. Some of the other therapies are for specific circumstances, for those higher risk patients, those higher stage patients, so those patients that have those higher risk genetics that we had mentioned earlier. There's some of the recommended therapies, including 4-drug therapies, may be required. And in certain circumstances of other comorbidities that those are, or other diseases associated with myeloma, such as amyloidosis, that other drugs may be employed in the treatment induction therapy for myeloma. It's really important to discuss that for African American and Black patients, and in patients of other ethnicities, such as Hispanic patients, that the time of initiation of therapy can be delayed. It's important to know that, and really important to understand that Black patients are most likely to initiate first-line therapy for myeloma, and their delays. Patients of African Americans have lower stem cell transplant utilization. Again, it's so important to get a stem cell transplant if you're eligible for it, because it helps drive the disease down that much further. But what is really important to know is that when they've looked at the outcomes, all things being equal, Blacks and whites and people of all ethnicities have very similar outcomes when both in clinical trials and using standard of care. And so we definitely need to work on trying to get people of other ethnicities more involved in clinical trials, utilization of stem cell transplant, and immediate initiation of therapy. The main body systems, again, affected by myeloma, include the blood, causing low blood counts, but also within the drugs that we use and the disease itself can make the risk of having blood clots that much higher. So when patients are under induction therapy, sometimes we'll put them on an aspirin and sometimes blood thinners in order to prevent blood clots. Also, peripheral neuropathy. The disease itself, the antibodies can cause damage to the nerves, causing neuropathy, but also the medications that we use can cause neuropathy, usually beginning in the hands of the feet and moving upward. So make sure that you tell your provider if you're having neuropathy, because there are things that can be done to help the neuropathy, especially if found earlier. Cardiovascular side effects. So some of the medications can cause high blood pressure. The steroids can sometimes cause high blood pressure and congestive heart failure. So make sure you tell your doctor if you're having shortness of breath or leg swelling or difficulty in ambulating due to a cardiovascular side effects. And gastrointestinal. Although the drugs that we use don't cause a lot of nausea, they can cause constipation and diarrhea. Again, it's important to have communication with your provider because there are solutions to all these problems if you let us know about it. Again, for the past 100 years, we've been using steroids. They're important for the treatment of myeloma. We have clinical trials going on right now. They're trying to remove it from myeloma therapy, but right now we are still dependent on using steroids to have our myeloma treatments work that much better. They have a number of side effects. They can cause sleep disturbances, and they can cause people to have mood changes. They can have people have fluid retention, and they can have leg swelling. So it's important to monitor your weight on a regular basis. We talked about mood changes, including irritability, difficulty concentrating. Sometimes patients can have depression with the steroids. So it's important to communicate, again, that to your provider because the things that we can do to help with that. Steroids can also cause heartburn, and which can be exacerbated by some pain medications, including non-steroidal anti-inflammatory drugs. Acid blockers work really well at preventing heartburn from it, and the steroids can have elevations in glucose. So it's really important for your provider and your primary care doctor to be in communication and making sure that the blood glucose levels don't get too high, and if you need any medications to control the blood glucose levels. So where's the field going? I've talked about how there have been breakthroughs for myeloma, having patients live longer and driving disease down lower. There have been marked advances in staging and genomics and imaging in myeloma. We're getting better and better at that. We talked about how 3 drug therapies are being used for myeloma. And really, there are lots of different clinical trials ongoing in using 4 drug therapies for myeloma. Again, driving disease down lower to have it that much longer for it to come back. Precision medicine. So we talked about how there are various mutations that are behind the occurrence and progression of myeloma. If we can leverage some of those mutations and treat those mutations specifically, especially the 1114 translocation, which appears to be more sensitive to specific drugs like venetoclax. That is a very, very hot area of research. MRD-driven therapy. Not just driving the disease so the protein disappears, but driving the disease down so we can't find one myeloma cell in over 1 million normal cells. So MRD-driven therapy, and trying to reduce the long-term toxicities of treatments to make them more specific, to have less side effects, and of course, new classes of drugs and immunotherapies to harvest the body's own immune system to target against myeloma. So clinical trials have really been the hallmark of what has improved survival so much in multiple myeloma. There are phase 1 and 2 trials in a number of different, not only novel therapies, but in immunotherapies. And you see there is an embarrassment of wealth in the clinical trials that we have in order to find a solution and a cure for myeloma. In phase 3 trials, which are registration trials, so we can get that much closer to having a drug that's FDA approved, and those investigational therapies. So I would encourage you to be involved in clinical trials with these new and exciting therapies for multiple myeloma. So in summary, myeloma is a blood cancer that can affect the bones, kidneys. It can raise the calcium level and involves the bone marrow, leading to lower blood counts and increased risk of infection and sometimes decreased kidney disease. It's a cancer of the immune system. Therefore, infection prevention is key. Bone marrow biopsies not only diagnose the disease, but give us an insight into the biology of disease. What mutations cause the disease? And can we leverage those mutations for therapeutic options to fight myeloma? Survival rates are improving. We've had now 15 new drugs approved in the past 14 years for the treatment of myeloma, which is resulting in better outcomes for everyone with myeloma. And the treatment paradigm will continue to change because there's so much activity in us trying to cure this disease. So it is critical for you to be an informed and empowered patient, to surround yourself with a healthcare team that's also empowered, so you will better be able to cope and live with this disease. Thank you.
Hello, everyone. My name is Dr. Brandon Blue. Today, we'll be talking about autologous stem cell transplantation, continuous or maintenance therapy, and treatment goals as it relates to multiple myeloma. Really, as a doctor and as a patient, one of the main things that we do is we have to decide from the very beginning, is this person a candidate for autologous stem cell transplantation? Because that dictates how the treatment will go. For example, if we determine, yes, someone is a candidate for stem cell transplant, then the typical regimen is that someone will do somewhere around 3 to 4 cycles of induction chemotherapy, followed by stem cell collection and then storage. Next, we do the high-dose melphalan and stem cell transplant, followed by either consolidation or maintenance therapy and then supportive care. However, if that person is deemed not to be a stem cell transplant candidate, then we can use really any of the regimens that are typically used for multiple myeloma. However, we omit the stem cell transplant section. But let's talk more about that. Autologous stem cell transplant is very complicated, so we really want to get into the weeds and talk more about exactly what it is and how we can help you with stem cell transplant when it comes to multiple myeloma. So one question that I always get is stem cell transplantation surgery? The answer is no. But one thing to know is that it is high doses of chemotherapy. And the good thing about those high doses of chemotherapy is that it actually offers a longer time that your disease is under control compared to those who don't. One thing to know is that it can actually be used at the very beginning, meaning that after those 3 to 4 cycles of chemotherapy, then the next step after that should be an autologous stem cell transplant. And for a lot of people, it's really considered to be much more accessible than in the past, meaning that we're doing stem cell transplants on patients older and older, which wasn't the case many years ago. So what does transplant mean? One thing to know that in your blood and in your bone marrow, there are these seeds or stem cells that make new blood cells. For example, white blood cells, red blood cells, and platelets are all cells that your body uses. So if your body uses it, that means you need to make more. Where's the place that you do that? In the bone marrow. And so we use these stem cells in order to make new blood cells all the time. And that's something that your body has been doing its entire life. However, what we do with the stem cell transplant process is that we actually collect these stem cells that kind of act as seeds that can actually grow and make new blood cells. Once these seeds are collected, then what we do is high doses of a medication called melphalan. It's a chemotherapy that will help eradicate those myeloma cells, not only from the blood, but also from the bone marrow. Because this melphalan, reduces all the cells in the bone marrow, it actually takes out the normal cells and the cancer cells. So what that means is now we have an empty bone marrow. So that means someone is severely immunosuppressed and they don't have an immune system that can really fight off infections once the transplantation process is taken. And so what that means is that since the bone marrow is empty and you actually need an immune system to fight off infections, we actually take those seeds or stem cells and actually put them back in the person's body in order to grow and make new blood cells. Let's actually talk about the transplant process. Induction chemotherapy, as we talked about, is around 4 cycles of medications that will take your cancer from a high level to a low level. But because we all want it to stay at a low level for a long period of time, that's where transplant comes in. So once that 4 cycles have happened, then you move to step 2, collecting the stem cells. As I mentioned before, the stem cells are little seeds that make new cells. However, these stem cells live in the bone marrow. We actually have medications called Neupogen and Neulasta, Leukine, that can actually move these cells from the bone marrow into the bloodstream. So that when we need to collect them, there's an IV process called a catheter that is in place, and we can actually collect these stem cells from the bloodstream. Once they've collected, we can freeze them, and they're actually good for decades in the freezer, frozen. Now that we have these nice, juicy stem cells in the freezer, they're ready to go to the next step, which is actually the high dose of chemotherapy called melphalan. The melphalan is actually given 1 day, 1 time as a high dose of chemotherapy. And then after that, what happens is that we actually take those stem cells that are frozen, we thaw them out, and then we actually reinfuse them into the person's body. After that's done, then those stem cells will make their way into the bone marrow, and as all seeds do, they have nice fertile ground and they grow, and what was once an empty bone marrow is now a fresh bone marrow made of now newly replenished cells. The last part of the transplant process is the recovery. Because of the high dose of chemotherapy, it does take a while for someone to have a full recovery. On average, somewhere around 2 to 3 months. Typically, we round it off and say for the first 100 days after a stem cell transplant, someone is considered immunosuppressed or immunocompromised. So let's talk about the data. One of the main questions that people ask us is, should we get a transplant now, or should I just wait until the disease relapses? I'm glad you asked. So research actually shows that in people who got the early transplant, meaning they got those 4 cycles roughly of that induction chemotherapy, followed by a transplant, typically had a longer time of disease control compared to those who didn't. So we followed these patients out for about 2 years. And we say, well, at 2 years, the folks who actually had a couple cycles, typically around 4, and then transplant, had an average of about 50 months of disease control before relapse. Compare that to those who didn't get the transplant right away or up front. The average was about 36 months. So 50 months compared to 36 months, typically that's where transplant really makes the benefit, is up front. If we follow people out for those 2 years to really kind of make that benefit compared to those who didn't. However, we looked at overall survival, meaning that, all right, we know that it actually keeps the disease under control, but does it actually help you live longer? One thing to know is that from a research standpoint, we actually follow patients out 4 years. And we looked at those who got induction chemotherapy, those around 4 cycles of therapy, followed by a transplant as what we call the early transplant group. And those who had the early transplant group had about 50 months of disease control before the disease came back. Now let's compare that to those who just got the induction chemotherapy with no transplant. The average was around 36 months. So really, if you look at 36 months compared to 50 months, the transplant group really had a significant benefit. However, one of the questions that we want to ask is, will I live longer? So we actually looked at that, and that's called overall survival. We did not see a difference in overall survival compared to those who did the what we call early transplant compared to those who actually didn't get a transplant until later. However, previously we had looked at and trying to understand what happens long term. So transplant and myeloma is a chronic disease because unfortunately multiple myeloma is not curable. So we not only want to look at 1, 2, 3, 4 years, but we want to look at 10 years down the road because this is really a chronic condition. So we did that. And we actually compared those who had, again, that early transplant group compared to the late transplant group. And even if we go out 10 years, we actually did not notice a difference in either progression-free survival or overall survival. But again, this took a long time for us to follow up and actually see that there was no major difference between those two groups. So one question you might say is, well, why do this? What are the pros? What are the cons? How can this affect me? Let's talk about the pros first. The pros of early transplant is you're the youngest today that you'll ever be. Okay, and that's really important to know because, as I mentioned before, the treatment with stem cell transplant is high doses of chemotherapy. And you want to be as young and as healthy as you are, and there's no day like today in order to be that person. However, if you look at the cons of early transplant, you might say there's about 25% of people who may not need a transplant, at least right away. Then we also see that there's 20% of patients who still, despite transplant, unfortunately, still relapse within the first 2 years. There's about a 1% chance of serious or life-threatening complications. And again, I mentioned before, the recovery time, somewhere between 3 to 6 months to make a full clinical recovery. And as I mentioned before as well, there's no proven overall survival benefit of this early transplant. So let's just say you wait to transplant. What are the pros of doing that? Well, one thing to know is that you could not do transplant right now and actually have a better quality of life. Because if you think about it, transplant does have this recovery and high dose of chemotherapy, and that sometimes decreases people's quality of life, at least in the short period of time. So if you don't do that, some of the medications that we use for induction are tolerated relatively well, and people don't have those decrease in their quality of life, at least up front. Transplant can be very complicated, meaning that it's only done at major medical centers, and sometimes there's a major disruption in your lifestyle because you may have to relocate to a new city for a few weeks to months. And one thing to know that if there is what we call residual disease after the combination, sometimes it could be very complicated, but the overall survival difference is about the same. What about the cons of waiting for transplant? One, know that a lot of patients, somewhere between 60 to 70%, will relapse and actually may need it at salvage. And not all patients who relapse are actually able to undergo the transplant. So the problem is sometimes if you wait too long, and unfortunately this therapy that has really helped people, unfortunately you're not eligible for anymore, or you just may not be able to tolerate it. And so if you think about the median age of diagnosis of myeloma, you're already an older population. So if you continue to wait years for something that you qualify for today, unfortunately those years may never come. So in summary, one thing to know that honestly, autologous stem cell transplant is really the standard of care. And it really should be done really for those who are in the front line if the person is eligible. The safety is established, and one thing to always remember is that typically we do have much longer remissions with autologous stem cell transplant. That brings us to our next conversation about minimal residual disease. One thing as myeloma doctors that we have realized is that it's very important to know exactly how well someone responds to treatment, meaning that there's some people who, despite all our best efforts, only get about a partial response to treatment. There's some people who have a very good response, and there's some people who actually have a complete response, meaning that we give them medications and then boom, the disease is no longer detected in the blood or the bone marrow. But because medicine is always changing, there's a step actually above that now, which is called minimal residual disease, okay? And we want to detect that even at a much lower depth, is there some sign of these cancer cells still being around? And we do know that the lower someone's disease is, the longer typically they stay in remission. Let's talk about that. So if we use this iceberg analogy, and we know that as we continue to go down from newly diagnosed to complete response, or what we call stringent complete response, meaning that there's no detectable disease in the blood or the bone marrow, we actually have a test that can look even deeper than that. So a much deeper level to actually see, is there any cancer cells that can be detected? And sometimes the routine tests that we do as myeloma doctors are really not sensitive enough to detect these remaining cells because this is a deeper dive. So what is minimal residual disease? Sometimes it's important to know that just because things are negative doesn't really mean zero, because it just means undetected. Our machinery is always evolving, our technology is always evolving, and so we know that if there were zero cancer cells around, then there would be cure, but we're just not quite there yet. And so this is where minimal residual disease is really trying to say, well, I know it's undetected, but how low is it? And so it detects very small amounts of myeloma cells that are left in the bone marrow following what we call a complete remission. There's a lot of minimal residual disease tests that actually can look for one cell out of 100,000 and say, is there at least one? We take 100,000 cells. Of course, it's important to know that you have more than 100,000 cells. So, it might be what we call MRD negative, but it could be in 1 million cells and not in 100,000. And that's important to know, and we'll talk about those differences. So how is it measured? We use very special techniques that are actually always evolving and always improving. So flow cytometry and next generation sequencing are very important tools that let us know that, hey, is there any cancer cells detected or not? All right. And so one thing for us to know is that the depth of our detection keeps getting better and better and better, meaning that right now we do 1 in 100,000, but there's some tests that may be looking at 1 in 1 million, but you have more than 1 million cells. So then we want to look at 1 in 10 million, 1 in 100 million. So as things get better, we can actually know, is there cancer there or not? Because sometimes that dictates our treatment. Do we want to continue or not? Or is this person looking at something like a cure? Those are things that are still on the horizon, but something that we're really excited about in the myeloma field. So key terms to consider. I use this word MRD, so this minimal residual disease positive or MRD negative. This may be something you want to ask your doctor about, and if they give you these terms and say, hey, you're MRD positive, really what they're telling you is that based off of these tests, there are some myeloma cells that are still detected. Even if it's 1 in 100,000, they still can detect them. Or they look at this MRD negative term, they might tell you, and they say, well, really, based off of the tests that we have, there's none that are detected. However, just keep in mind, it could be 0 in 100,000, but really, if we took a deeper dive of 10 million, it really might be 1 in 10 million. So it really might be detected, but we just don't have the technology, unfortunately, to really do such deep dives quite yet, but there will be more to come, hopefully, as the years evolve. So one of the things that is important is to know that MRD really allows us to do this test to say, is there any cancer cells left? And because multiple myeloma is a bone marrow cancer, the best way to answer that question is actually from a bone marrow sample. So when someone says, all right, I want to know, do I have any cancer cells left? The best test and the best source of that test is to actually get these samples from the bone marrow. But you say, well, what about other areas of the body? Unfortunately, we know multiple myeloma likes to affect certain organs, such as the kidneys. It also likes to affect other places, such as the bones. So in order to say, hey, someone is MRD negative or no cancer cells detected, sometimes we have to do extra testing, such as a PET scan or MRIs, just to confirm that, unfortunately, these cancer cells haven't relocated to another part of the body. So you might say, well, why is it important then to do this minimal residual disease testing or to be MRD negative? There's been a lot of studies that have really kind of looked at this question to say, why does it matter if it's 0 in 100,000, or even if they see 1 or 2 in 100,000, isn't that still good? Well, we know what's good, but we also know what's great. Typically, MRD negativity is great, while MRD positivity is good. And when you say, well, what does that mean? It means that typically these levels will determine how long someone stays into remission. And so there's been multiple studies that have looked at that, whether they looked at the initial therapy, stem cell collection, doing transplant versus no transplant, but then actually doing these MRD assessments. They've actually been able to see that those patients who actually had MRD negativity, meaning that 0 in 100,000, actually have a longer remission than those who are still positive. So if you look out 5 years, if you are MRD negative, at least according to the study, greater than 50% of the patients were still in remission. Unfortunately, those who were MRD positive, less than 25% were still in remission. So we really see that MRD positivity or negativity really determines what happens in the course of someone's disease. And so based off of that, that's why we really aspire to achieve MRD negativity through the various treatment modalities. And so really some of the key points is to know that those patients with MRD negativity not only had longer time of disease control, but actually live longer. And that kind of makes sense because, if the disease is not coming back, then that's less bones that are being broken, less kidney damage that can happen, less dialysis and those kind of things. However, one of the things that is not yet quite understood is that not all myeloma is the same. So does this also matter for patients who are considered with high risk? More information is still needed on that, but just know that in a general sense, MRD negativity is still the goal, and that's something that we should all try to shoot for. So much so that a lot of the ways that drugs are being developed and clinical trials are being developed right now, we're really trying to answer this question to try to figure out, what do we do with the MRD result? Like, how do we know if someone's MRD positive? Do they need more treatment or not? Or what if someone is MRD negative? Can they stop treatment? Those are questions that are still being investigated. And if they can't stop, for how long? And so really a lot of clinical trials are really trying to figure those kind of questions out, is how to use these different tests and make decisions off of them. Not only that, but technology is also advancing to try to figure out, well, right now, if we can look at 1 in 100,000, let's keep going, further down that iceberg and look for 1 in 10 million, 1 in 100 million, because you have much more cells in your body than that. So MRD responds to adapted consolidation of treatment. So this is very important. So some clinical trials basically use this minimal residual disease to determine, should we continue or not? And so let's take this example. If you have a new diagnosis of multiple myeloma, one of the studies said, well, let's give you a lot of different medications, as we typically do, to bring your disease burden down. Darzalex, Kyprolis, Revlimid, dexamethasone. And then they do one of these MRD assessments, okay? And then they continue to transplant. However, if you're MRD negative, then you were just observed. Then they say, well, someone's MRD positive, let's continue with treatment. And they kept doing these MRD assessments basically until someone was on Rev maintenance. And so one thing to know about this study, that it was fantastic, 80% of those patients achieved MRD negativity, and 66% achieved negativity at an even deeper level. So I think this is really the best way that we can do that, is really try to make sure that these drugs are working, and not only are they working, but they're actually leading to deep responses with MRD negativity. Also to know that about 86% of the patients achieved what we call a complete response or better. So this is saying that if we give, a lot of different medications, then we know not only is it making the disease go away in the blood and the bone marrow, but we're actually not even able to detect it by some of the most sophisticated tests that we have. Also, too, one thing to also remember, as we talked about the importance of autologous stem cell transplant, that autologous stem cell transplant does increase the rates of MRD negativity following that induction. And again, if MRD negativity is the goal, transplant sometimes is the vehicle to get us to that goal. So it's also important to know that nearly all the patients with no or only one high-risk abnormality and confirmed MRD negativity had no disease progression or MRD resurgence since stopping treatment. So that's one thing. This isn't quite mainstream yet, but this is where clinical trials and this is where myeloma treatment is going, trying to figure out, is this something that we can actually stop treatment for those folks who have achieved this MRD negativity. So, as I mentioned before, MRD negativity is something that is detected from a bone marrow because, as I said before, this is a bone marrow cancer. However, as everyone who's had a bone marrow done before, those aren't the most pleasant tests. So if there's a way to detect the same information from a blood test, that's, I think, a little bit more appealing. And so we're trying to use a technique called mass spectrometry that has been very widely used for detection of myeloma for many years, but trying to use it in this MRD setting. And so there's been some clinical trials that have really been able to use mass spectrometry to really associate with someone's disease. And so, it's an alternative that's being studied right now to detect MRD or not. And really identify those patients who are at risk for having early relapse. So just know that this technique of mass spectrometry is very cutting edge. It's something that you will hear more about. And it is something that, again, is a blood test over a bone marrow test, but still gives you a wealth of information. So in summary, MRD is the deepest response after myeloma treatment, including bone marrow MRD and imaging MRD. So sometimes we use this next generation sequencing and flow cytometry, really two of the most common tests that we use to explore MRD. But just know that right now we're looking at other things such as mass spectrometry to look for blood-based tests to look for MRD. MRD has been associated with longer progression-free survival and overall survival, meaning the time that the disease stays under control and how long you live are typically better for those who are MRD negative. And they predict those who are at risk for progression. The modern combination of therapies that we're doing now are really increasing higher and higher percentage of people who are actually achieving this MRD negativity. Also, just know that some of your treatment decisions may be based off of MRD response, meaning that your doctor may offer more or less treatment based off of if you're MRD positive or negative. And also it's useful to know that MRD is really being incorporated in some of the research and clinical trials that we're doing right now, and actually new drug development, because if there's new drugs that are coming out that are really improving this MRD negativity rate, then that's a drug I think we all would be excited about. Lastly, let's talk about continuous or maintenance therapy. So what is maintenance therapy? So one thing to know is that, even after the disease has gotten under control, even after you've been on, all these medications for such a long period of time, one thing that us as the doctors will recommend to you is to keep on some type of medications, typically at a lower level, to help prevent the disease from coming back at a longer period of time. Okay? And so, maintenance therapy basically helps keep the disease under control for a longer period of time. And typically, it's not as intense as the medications at the very beginning, but typically at a very low level, that does help. So it's typically a prolonged and often low dose treatment given to myeloma patients after the initial therapy. And again, not as intense. It likes to prevent the disease progression for as long as possible while maintaining what we call a favorable quality of life. As I said, multiple myeloma is a chronic condition. And so what we want to do is really improve your quality of life and make sure that the life that you live is not only long, but meaningful. And we want to, eliminate what those things are, MRD, and reduce the risk of relapse and prolonged survival if possible. There's typically about 3 steps that the doctors use to try to figure out if this is appropriate for maintenance therapy. Number 1, it must be convenient, meaning that we can't have you coming to the cancer center every day for the next several years and calling that quality of life. We want it to be convenient for you, some type of typically at-home therapy that you can do and reduce your recurrence of coming to the cancer center. Also, be safe and well tolerated long-term. As you know, some medicines are good in the short term, but really if you take them for years and years can create problems. And so We don't like that as the doctors, and so we would like to give you medications that are both safe and well tolerated. And then number 3, not interfere with the use of other treatments. So because myeloma isn't curable, there a lot of times is relapse and future treatments in someone's future. We need this maintenance to be convenient, safe, well tolerated, and not interfere with those future treatments. So let's talk about the risks and the benefits of maintenance therapy. So anti-myeloma benefits of continuous or maintenance therapy is always balanced with the side effects because we do know that typically those folks who are on maintenance do have a longer period of time that their disease is under control. But a major concern of anyone who is taking maintenance therapy is that really the side effects and that this long-term use can compromise the ability to receive treatment in the future. And that's something that I know patients and people struggle with, is that, hey, I just got my disease under control. I just had a transplant, and you're telling me I still need more medications? Yes. And it's really because this maintenance does keep the disease under control for a longer period of time. Really, one of the gold standard medications that we use is Revlimid. And Revlimid has been shown in large studies to really improve survival for maintenance therapy. And also, one of the things that we know that is really approved, and really one of the only medicines that's approved for the maintenance therapy after autologous stem cell transplant. Nothing in life is free. Sometimes we do have side effects that are associated with it. And there was a small study that did show that there was increased risk of secondary cancers when used with melphalan. So let's actually talk about the data on that, and let's look and see exactly what I mean. So if you take those patients who used Revlimid as a maintenance strategy, okay, and those, again, who achieved this MRD negativity, we see that the amount of time that the disease was under control was much longer than those who had this, what they call MRD positivity, all right? And so, again, MRD negativity is really the goal, all right? And that's really the plan and why we want to do this. So this question comes up all the time is, can I stop? I've had my transplant. I had my disease under control with the original chemotherapy. I actually started my Rev maintenance, and I've been on it for a while. Can we stop? One thing that, if patients have questions, us as doctors sometimes really try to do the research to answer some of those questions. And that was actually done in what they call the Stamina trial, where they took patients and they actually stopped Revlimid after 3 years. As you can clearly see, those who stayed on continued Revlimid had much better time of disease control than those who stopped. So unfortunately right now, discontinuing Revlimid, even at 3 years, is not recommended because it significantly increased those people's relapse rates. So it's nice to have a break from treatment, and I do understand that, but just know that the doctors are doing it for a reason, and that reason is proven and backed by science. As I mentioned before, one thing that is a concern, and one of the things that the doctors will be monitoring for, is what they call second primary malignancy. So you say, what is that? Meaning that you already have one cancer, which is multiple myeloma. However, other cancers sometimes can pop up. They do see an increased percentage of that in those who are on Revlimid or lenalidomide, in both not only blood cancers, but also solid tumors. So one thing that I always tell patients is that, once your body opens the door for one cancer, unfortunately, sometimes other cancers do pop up. So that means just because you have myeloma doesn't mean you need to forget about your mammograms, doesn't mean you need to forget about your colonoscopies. Other cancers are still possible and should be evaluated because you're at a higher risk. And so screening is very necessary even after a diagnosis of multiple myeloma. So what are the options for someone who has determined that they need maintenance therapy? For most patients, Revlimid is considered the preferred maintenance medication. However, due to certain issues, it could be other medicines such as Nalaro or Velcade. Under even certain circumstances, such as those patients who may have what we call high-risk multiple myeloma, we actually may use 2 different drugs, meaning they could have Revlimid and Velcade, or even some patients, we even slide in dexamethasone. And so just know that not all myeloma is the same. This is a discussion that you would have with your doctor, and just know that there's clinical trials and information out there trying to decide, are there other medicines besides Revlimid and Velcade the best ones for maintenance, such as Darzalex, Kyprolis. What about those medicines? It's still under investigation, and there'll be more to come. So in summary, there's a big body of evidence that shows that maintenance therapy improves what we call progression-free survival, or the amount of time that disease is under control, and even likely overall survival. And really it should be given not 1, not 2, not 3 years, but really continuously until the disease progresses. And also to know that most patients should receive maintenance. Revlimid is one of the standards because it's definitely tolerated well and convenient and does not typically interfere with those future treatments. Of course, your medical team will always try to minimize the side effects and actually maximize your quality of life. The dose of Revlimid that we typically prescribe during maintenance is standard. However, it can be adjusted to improve quality of life and minimize those side effects that are associated with it. However, not everyone tolerates Revlimid. There's other ones to use, such as Nalaro and Velcade, as I mentioned before. Things investigations such as Darzalex and Kyprolis are really deemed under investigation, and there'll be more to come, even if they aren't FDA approved as of yet. So thank you for your time, and I am Dr. Brandon Blue from Moffit Cancer Center, and this has been a review of autologous stem cell transplant, minimal residual disease, and maintenance therapy as it relates to multiple myeloma. Thank you for your time today.